all of you and the organizing committee and scientific committee of this highly organized conference. My presentation will be about endoscopic ossiculoplasty various techniques. First of all, what is the criteria of best ossiculoplasty? It should contain or include removal of the pathology in the middle ear, attic, even the mastoid, with normal or slightly hypertrophy of the middle ear mucosa, with preserve or restoration of the posterior meatal wall, attic, with the preservation and restoration of the ossicles, especially the malleus and the stapes, with the preservation or restoration of the middle ear space, tympanic membrane, and middle ear mechanic, with patent tympanic isthmus, patent gestational tube, and patent adhesive antrum, by using a short time procedure with using non-reactive and non-disease transmitted procedure with low-cost ossiculoplasty. As a comparative between the hearing result between the endoscopic and microscopic, there is no significant statistical difference between the hearing result between both techniques. Also, as a comparison between the procedures or the autograft, also there is no significant difference. Middle ear mechanic is one of the important factors in correction of the hearing. The surgeon should have many than one technique in the correction of the hearing in the same surgical situation, and be ready and to avoid the possible complication during ossiculoplasty. One of the important points, correction of the hearing, it is not only by surgery, can be corrected instead of surgery by hearing aid, adhere, or BAHA. Finally, the post-surgical point of view is your patient satisfaction. This is a case of eroded long process of the incus with encodostapedial joint dislocation. A simple technique can be corrected by interposition of a piece of a graft of cartilage like this. Another option can be applied by using of a glass ionomer to correct the continuity between the incus and the stapes. With little large gap like this, can correct it also by technique of using of glass ionomer. In a large defect like that, between eroded of the long process of the incus and the stapes can be corrected by using different modality of prosthesis. Another option can be using of a glass ionomer by making an bridge by a piece of gel foam, then apply of this a piece of gel foam, then apply of your glass ionomer and wait till be dry, and this post correction, very nice ossicular mobility with good light reflex. This is another case. This is a longer process of the incus and this is stapes. This post correction. Also, some situations need procedure or prosthesis. Also, another sometime modification of a piece of cartilage, what we call pantalon ossiculoplasty, making a shape of a piece of cartilage like pantalon, then apply the lower part over the head of the malleus, of the stapes, and reshape the area in between and engulf the long process of the incus. Then check the ossicular mobility. Here is very nice. This is a mobility. This is a patient of Post-traumatic incudostapedial dislocation with ankylosing of the incudomalleolar joint. Try to relieve the ankylosis with trinodal disruption of the incudomalleolar joint. After check of the mobility of the stapes, correction can be done by using of glass ionomer like this case. Only one case, we have another option by using a piston between the long process of the incus and the foot blade in between the anterior and posterior crust of the stapes. Another option can be applied by removal of the incus and remodeling the shape to be interposition between the malleus and stapes like this. This is another case of incus interposition. This is the malleus, this is the incus, and this is stapes. In case where there is no or fully eroded of the incus, we can use a certain type of prosthesis, but still, malleostapedipexy have a little rule and a very unacceptable result of hearing like this patient, where completely eroded of the incus. This is stapes, here is the malleus. After release of the malleus, and cut the lower part to have a raw bone area. Cut of the lower part of the ambu. Then relocation of the malleus over the head of the stapes and fix each to other by a drop of glass iron. If there is no incus, no malleus, only you have a mobile intact stapes, correction can be done by a graft of cartilage over head of the stapes, like this technique. Some surgeons use this technique of making a hole or frustration of the piece of the cartilage, then applied over the head of the stapes. Some concern about this technique, we can certain modification where making a hole in one side of the piece of the cartilage and preserving of the cartilage of the other side, then applying it over the head of the stapes, did allow a good coaptation between the cartilage piece and the stapes and making a space for middle ear. If there is no stapes, no malleus, no incus, no stapes superstructure, correction or the hearing can be done over the foot blade by what is called bone bear ossiculoplasty or L-shaped ossiculoplasty. Drill an area over the annulus, the tympanic annulus. Then an L-shaped cartilage will be applied, the long shaft as the drilled area and short part over the mobile foot blade. In otosclerosis, the usual technique, stapediectomy can be done, also endoscopic can be done like this case. Finally, in cases of stapediectomy, also can use a different procedures over a pericondral graft instead of traditional vein graft technique. Thank you.